Hello and welcome to Healthline 3. I'm Terry Simmons. Today we're talking about oral head and neck cancer with Dr. G.E. Ghali, Director of Oral and Maxillofacial Surgery with WK Oral and Maxillofacial Surgery Institute, also with the Willis-Knighton Health System. So we'll be taking your calls throughout the show, and as a reminder, please make sure you're in a nice quiet room with your TV turned all the way down before making your call. And you know the number is 318-219-4569, and we look forward to hearing from you on this topic. Dr. Ghali, thank you for being here.
Thank you, Terry, for having me.
Sure. Let's talk a little bit about what you do generally, and then we'll get more specific with actually head and neck cancer.
Sure. Well, I'm an oral and maxillofacial surgeon, and I've been here in Shreveport for nearly 3 decades, I guess. I moved here when I was 5 years old. So
Must have.
I'm 35 now.
Prodigy.
But thank you for having me.
Sure, we really love having you here. And I'm really fascinated. We were talking a little bit during the break about oral cancer and head and neck cancer. And actually, when you talk about head cancer, I was doing some research on what does that mean, because I knew it wasn't brain cancer. But when we talk about head cancer, tell us what all that involves and why it's so intricate.
It's interesting and intricate. You know, we learned in dental school and in medical school, you know, the head and neck is probably one of the most complex areas because, you know, you're dealing with the sense of smell, the sense of vision, the sense of taste, swallowing, everything. It's a very complex area, and clearly there's a multitude of blood vessels and nerves and such that run in that area. So it's very, very complex. And so we're talking about malignancies, cancers, carcinomas and maybe sarcomas and maybe lymphomas that occur anywhere in the face, around the eye sockets, around the nose, nasal cavities, sinuses, palate, mouth, throat, neck, and of course in the thyroid and parathyroid glands as well. So it's a very complex area, and as I mentioned earlier, only about 5% of cancers involve the head and neck, if you look at the total body. But of those 5%, they all involve some form of intricacy related to our ability to speak, or ability to taste, or ability to speak, swallow, eat, and things like that. Kiss, I mean, all these things are involved. And so it's an area that has a huge impact. If you look at cancers of the head and neck, there's about 70,000 new cancers of the head and neck in the United States each year. If you say, well, gosh, how does that compare to, say, breast cancer? It's about there's about 4 times the number of breast cancers than there are head and neck cancers. But again, the intricacy of the area is quite significant. Of those 70,000 head and neck cancers, and what I'd like to kind of focus on today as well is those that occur in the oral cavity and those that occur in the throat. So basically the mouth and the throat area, and that really represents about 2/3 of head and neck cancers are ones that occur in the mouth and in the throat. And those are the ones that, interestingly, we as healthcare professionals have a big impact on, particularly the dental community. Dental hygienists and dentists in general, you know, they're the ones that can pick those up early. Sometimes it's difficult to pick up early on a breast cancer or on a colon cancer or on a prostate cancer, but the mouth is so accessible. And we ought to be going to the dentist twice a year and getting our teeth cleaned and our mouth examined with an oral cancer screening. So if that's done properly and done on a regular basis, cancers ought to be picked up early enough to have a significant impact on the survivability.
It's really so interesting you bring that up, because that's what I was thinking for my question here, is that something, never thought about it, but is that something that you think it might be obvious, but is that something a dentist also is trained to look for?
Absolutely,
yeah.
Absolutely. Generally, an oral cancer screening exam is done at least once, preferably twice a year, by your dentist when you go in.
Oh.
And you should ask them, are you doing an oral cancer screening exam? And if it's not done by the dentist, it ought to at least be done by the dental hygienist. Both are qualified in doing an exam. And frankly, Terry, it only takes about a minute to a minute and a half to do a fairly thorough oral exam. They would look in your mouth and look in your throat, around your tongue, roof of your mouth, maybe feel your neck for any enlarged lymph nodes. And so that's all appropriately done at a dentist's office, and really is an easy way to screen. And then if anything is found, then oftentimes the patients will then be referred to either the oral surgeon or to the ear, nose, and throat doctor for further evaluation and testing.
So that's something we might not even realize that's what they're doing. It's just a typical thing. They might reach in and squeeze your cheeks and your lips, and while they're
squeeze your
looking around.
lips, squeeze your cheeks. Maybe take obviously wear gloves, and they grab your tongue with a little gauze and pull it out and move it one way and another. It's not like they particularly like to feel your tongue, but I think it's because they want to move things around so they can better visually inspect the area.
Yeah, never realized that's what that was for, but that's yeah. So is that first of all, how common is oral cancer? And how often should it be screened? If it's not by your dentist, should we mindfully be getting screened once a year, even if you don't have it? Like sometimes we hear, I have several questions in one here. You hear a lot of oral cancer, and people say, "Oh, are they a smoker?" That's the first thing they ask. Smoker? Right. Do they dip or chew? A lot of times in this part of the country.
Well, Terry, that's a good question.
Oh, well, thank you, doctor. So answer all that.
That's a good question. Well, when it comes to what the cause of cancer, I mean, just smoking in and of itself is probably responsible for about 50% of the cancers in the entire body itself, particularly cigarette smoking. There's a whole other issue with other forms of tobacco, which aren't necessarily as well correlated with the development of cancer, but there is a relationship. And certainly with cigarette smoking, with vaping and things like that, that's a whole nother topic. But about half of the cancers in the body are in some way or another associated with cigarette smoking. The other half are not, and then of those other half that are not, there's various other causes that could. Probably one of the best documented causes of throat cancer, not necessarily mouth cancer, but we're talking about throat, like the way in the back of the tongue, maybe your tonsil area, maybe what they call base of tongue and tonsil area. There's been a lot of research done in the past 10 to 15 years looking at HPV, the human papillomavirus, P16 HPV, the same virus that causes cervical cancer in women, has been really linked quite closely with many of the cancers that occur in the throat. Indeed, about 70% of the cancers that occur in the throat nowadays, at least 2/3 to 70%, are HPV positive. So one could say that throat cancers, many of the throat cancers we see nowadays, could be considered to be a sexually transmitted type of disease. Fortunately, there's a vaccine that exists nowadays, particularly administered to adolescents, that may help with, so you don't catch the HPV virus. But fortunately, the HPV-associated cancers, Terry, do a lot better.
Oh.
They have a better prognosis related to proper treatment with radiation and chemotherapy.
Wow, that's fascinating. So I do want to know about the treatments and what happens once you find out that you do have this type of cancer. How else is it screened? Like besides we talked about the dentist, and is there something we find ourselves and we look, how does this happen where it progresses?
One of the misconceptions about cancers, particularly oral cancer, is that it's painful. And typically it's not painful. Many of the early signs of it are, I just got a bump or an ulcer. And oftentimes there's no pain associated with that. So self-screening is very important. As we mentioned, kind of looking in your tongue and things like that when you brush your teeth, and hopefully everybody brushes their tongue as well. And because the tongue and the floor of the mouth, which is the area right underneath the tongue in the front, those are the two most common areas for oral cancer.
Oh.
And so those are areas that are really accessible to the patient for them to see themselves. And I'm not saying to obsess and to look every single day, but I would say you looking a couple of times a year, and at least the dentist looking once, if not twice a year, or the dental hygienist, is really the way to screen it. The best way to do a screening exam for oral cancer. And then if you see something that's suspicious, bring it to the attention of the dentist, and then they will then evaluate you and refer you to the appropriate individual.
And then what happens? Like, how is it, there's a screening, but how is it actually
Right.
diagnosed where you find out?
The actual diagnosis is done by biopsy.
Okay.
And so there's really the gold standard is to biopsy. It's easy to get to. The surgeon or the dentist or surgeon will numb the area up and take a little piece of that tissue and submit it to the pathologist, and usually within a week you'll have a result of what it is. And the most common cancer that occurs in the oral cavity is squamous cell carcinoma.
Okay. And how serious is that?
Pretty serious.
Pretty serious?
Yeah, it's pretty serious. If this cancer can be caught in stage 1 or stage 2, the cure rate is much higher. As a matter of fact, stage 1, where you have a very small little bitty cancer, early type of cancer, has a cure rate of probably 90 to 95%. Once you get to stage 3, the cure rate drops to about 40 to 50%. So that means about half of those patients will have died by the time at the 5-year interval.
So this is something that's potentially fatal, not just that you would lose part of your. What are the different things that can happen if it does go too far, or what happens with the treatments? Is something removed? Is there?
Right.
How does it treat it?
Well, the treatment, if I back up and say it is a serious cancer. Oral cancer, it's different than, say, skin cancer. When we talk about cancers that happen on the skin, squamous cell or basal cell cancers, we're not talking about melanomas. We're talking strictly about squamous cell or basal cell cancers. Those are fairly indolent. They don't tend to spread very quickly or very easily, and they have a very high cure rate. Oral cancers tend to spread quite early. And so picking them up, the earlier you pick them up, the better. As a matter of fact, sometimes when you go to the dentist and they screen you, they can see some of these little white lesions and red lesions in the mouth, and they may be overly cautious, but they will then refer you to get that biopsied. And a lot of times, if this can be caught in the pre-malignant stage, that's the best stage to catch it. Because then at that stage, you get the absolute best cure rate possible that you could get. The treatment for oral cancers or throat cancers, the mainstay of treatment is surgery, followed by chemotherapy and radiation in certain select cases, depending on what's found at the time of surgery.
Okay, so the best thing to do is, as soon as you see anything that just looks a little different, go see about it as soon as possible.
Absolutely.
Yeah, and maybe talk to your dentist too. I know I'm going to. I had no idea that's really the screening, and when you go every year or 6 months, that's really
they're
something
basically
that
the
they're looking
gatekeepers.
For.
The dentist and the dental hygienists are going to be the ones that are going to pick up a majority of the oral cancers.
I never even thought about being concerned about having an oral cancer screening ever, because do you think that that's a lot of people, they don't think about that, they don't think about oral cancer, or if they're not the typical thing that we talked about, because not every oral cancer is caused by smoking or any kind of habit like that. But if I'm not a smoker, I don't do any of that, and I might not think about oral cancer at all. I might not even think to look for it. Right,
but it's still, there's still a subset of patients. When we talk about the mouth itself, certainly the throat has a high incidence of nearly 70% of those are going to be HPV positive.
Right.
But just the mouth itself, you will find a significant percentage of our patients have no history of smoking, no history of drinking, no history of HPV or anything else, and have no family history of cancer, and it just happens. So what this is telling us, Terry, is that there needs to be more research in the area. There needs to be research focused on what are the genetically predisposing factors to developing oral cancer. I mean, you can have someone that's been smoking for, 50 or 60, 70 years and not have one, and then you can also have a patient that has it in their 25 years old. Fortunately, that's a rare instance, but it does happen.
And is it something that's hereditary? Is this one of those things to look at?
I would say probably not hereditary.
More lifestyle,
but
or
more probably lifestyle, and maybe there are some genetic factors that we don't fully understand at this time.
And we talked about the tongue and the floor of the mouth. Are there other places where cancer you see it developing, like the cheek or the gums or anything? Bone?
We see it all over the place.
Yeah?
in the mouth, in the salivary glands. There's thousands of salivary glands throughout the mouth. In addition to the big ones that you have in your cheeks and in your neck, there's thousands of small ones that occur throughout the oral cavity. So you sort of can get cancers there, but we see cancers in the tonsillar area, in the palate, in the throat, all the way down in the esophagus, in the larynx, in the thyroid, and in the parathyroid glands as well. Fortunately, we have the capabilities here in the Shreveport-Bossier area at all of the hospitals to be able to comprehensively treat these type of patients.
It really is incredible, and we're so fortunate in this area. I don't think we can say that enough.
Well, we are fortunate. I mean, I've seen patients that go for a second opinion at MD Anderson, and then they come back and say, they told us the same thing. We really would rather be closer to home for our treatment, and that's the important thing: being close to home and being close to where you can get support. Many of these patients that we operate on that have these tumors, and I've seen at least 6 this week already. They need full family support.
Yes.
I mean, they're going to spend a week or more in the hospital. They're going to need a week or 2 of rehab potentially, because a lot of times when we do these surgeries, we have to take tissue from other parts of the body and transfer it to recreate the defect.
Another story altogether. We can find out more about that. We have a caller for you.
Oh, great.
Hi, Lewis. Thank you for calling. What's your question?
Yes, I need to speak with the doctor.
Okay, go ahead. He's right here.
Hello.
Hello. How you doing,
Mr. Lewis? Yes. How are you?
Yeah. Okay. Yeah. Oh, yeah. I'm saying I'm not doing too good, but anyway, what I'm saying, I have cancer. I have cancer in the chest.
In your chest?
Yes. And back in December, they had found a spot. They had found a spot. What I'm saying, on my lung, and then it was a mass, and so I had to go get a biopsy, whatever you call that, biopsy.
Yes.
And then come and find out that it was, that it was cancer, and I had it right from my throat, what I'm saying, down my lens there. But I done had all my treatments and everything. I done had my therapy. I had my radiation and all, what I'm saying, and all that kind of stuff. But and then too, I got to go back to the cancer doctor. I got to go back on May the 8th. I got to go back. Well, when you put me up in the CAT scan,
right,
and see it's all gone. And but the question that I want to ask you is, and I was sitting there listening at you, saying that when you're in stage 3, you have 5 years, and you said in 5 years you'll be dead. But like I say, I hope that don't happen to me, and I hope it be all gone by the time I get back to until I get back, until I go get that CAT scan done. And but what I'm saying, I got a real terrific doctor. I mean, I got a nice doctor.
Right.
Dr. V.
I know
yes,
Dr.
sir.
V. Yeah, he's a good man. Well, Lewis, it sounds like you're on the right track. And when I was talking about stage 3, so each cancer is a little bit different. And the 5-year survival for oral cancer is about a 50% 5-year survival when it's a stage 3 cancer. So that means that 50% of the patients will unfortunately have passed away by the 5th year. But that also means that 50% of the patients are going to be alive at 5 years and could be alive for 10 years or 15 years or 20 years. So hopefully, praise the Lord, you will be in that category, Lewis, that that you'll be around bothering Dr. V for a long time.
Definitely. And Louis, we wish you well too with all of that. It sounds like he's really still strong and healthy and going to get those tests, and hopefully
like
he's
it.
already on that, hoping that it'll be gone next time he has that check. And it's so nice that he felt like he could call in and talk directly to you and figure that out and mention Dr. V. So Louis, we wish you all the best. And and we have another caller right now, Sheila. Hi, Sheila. Thanks for calling. What's your question?
Hi, how are y'all doing today?
We're doing well, thank you.
Hi, Dr. Ghali. I've seen a lot of your work over the years. Very good doctor. My question is I know you were talking about cancer in the mouth and throat. I have had in 2021 I lost my kidney to cancer. I've never smoked or anything in my life before, but now I'm having more dental problems. Do you do regular extractions? I have a broken crown, or is it just the things that you do as far as related to cancer of the mouth and throat?
Yeah. So we do extraction of teeth and things like that. But most of our focus, as you said, Sheila, is related to the head and neck cancer type treatment. But your local dentist, I don't know if you have a local dentist here, but they're absolutely more than capable, or the local oral surgeon's more than capable of removing any teeth that you need removed. Of course, we don't want you to lose teeth that you don't need to lose. So I think it's very, very important to see your dentist and make sure that those teeth are not teeth that you can save. Because you need your teeth from a nutritional standpoint, and particularly if you've had a history of you said kidney cancer, that you need to make sure that your nutrition is appropriate. On the other hand, you also don't want to keep teeth if they're infected, because with a history of cancer, you are de facto immunosuppressed. So, we don't want to have teeth that are infected that could be causing your, for lack of better words, your blood to be poisoned by bacteria if you're already immunosuppressed because of your history of cancer. So I agree with you. You need to go get checked out, and if it's something very, very complex, your oral surgeon or your dentist may send you to me, and I'm happy to see you.
Okay. I appreciate that, because right now I have a broken crown. Dr. Jeffrey Scruggs put me on some antibiotics, but this is not something that he does. But the thing is insurance, because I have Humana Gold Plus, and it's hard to find somebody that will work with you with that.
Yeah. Dr. Scruggs is a good dentist, so maybe, if you talk to him about that, I'm sure he'll help you out.
Okay, thank you so much,
Yes, ma'am.
Dr. Ghali, for your time.
Yes, ma'am. Thank you.
Yes, thank you so much for calling. Good questions.
Good questions.
Yeah, and it's really interesting too how cancer, we're talking about oral and head and neck, but the questions are, and we do, I think whether we worry about that or it's true, where you have cancer somewhere in your body, And then you do wonder, the big thing, is it going to spread somewhere else? Is it going to go somewhere else, especially if it comes up in, now talking to this about everything in the head and neck that could be affected is really a concern.
Well, it is. I mean, we see, fortunately it's rare, but we see cancers from the breast, from the prostate, from other areas that actually spread to the head and neck area. Usually it's just the opposite. The head and neck one spread somewhere else and into the lymph nodes and maybe to the liver or the lungs or the brain. But we see other cancers that spread to the head and neck as well.
And this may be a question too long of an answer when we only have for about 3 or 4 minutes, but is there any pattern to where something spreads, the trail, the pathway when you get cancer somewhere in the body?
There is. There is. That's the whole theory behind, you might have heard particularly with melanoma, where they do a sentinel node biopsy, where they actually inject the dye into the melanoma, and they take almost like a little gamma probe or a Geiger counter, because cancers tend to spread, carcinomas tend to spread through the lymphatics, and sarcomas tend to spread through the blood, hematogenously. So if you know that, particularly with the sarcomas, it's your best bet because it spreads through the blood everywhere. The lymphatics tend to have a bit of a more organized pattern of spread. So if I've got a cancer, say for example, on the lip, I know that it tends to spread to the different levels of nodes in the neck. And so that whole process of understanding that allows us to selectively sample lymph nodes in certain areas. You have a breast cancer, it goes to certain lymph nodes in the axillary area, and those are the ones that are sampled by the general surgeon, by the breast surgeon to assess. So there are patterns. I'd like to say they're 100%, but they ain't 100%. But they ain't. But we know. Yeah, we know.
Yeah. Well, that's very interesting, because sometimes we might think that lymph nodes and the breast cancer just because it's proximity. I just thought it's because they're close.
Yeah.
But that's not really true.
It's not necessarily proximity.
Right.
Yeah. We see that sometimes with midline cancer. Something's close enough to the midline, we may end up doing both sides because of that.
Right. And is this done robotically? Can you do these surgeries
We can do some of them robotically, particularly the cancers that involve the base of tongue or the tonsillar area. Back in the day, we would have to do a much more aggressive surgery, and now we can kind of do that. But I think the one important thing I want to say about head and neck cancer at the end is multidisciplinary management is important. This is a team effort with dentists and physicians and surgeons and hem-onc doctors and speech folks and radiation oncologists and therapists. I mean, it is truly a multidisciplinary approach in getting the best optimal treatment for the patients.
So glad you brought that up, and that's a great note to end on. It really does. There's a whole team of people that are involved in this, because you talked about, as we began, this just brings it around to what we first talked about. There's so much involved in head and neck cancer.
So much involved, and the more help you can get, the better treatment for the patient.
Right. And so always start with your primary care physicians and
primary care, dentist, and then go from there. And don't be afraid, because there's good help around here for you.
Oh, so much good help here, so much. And talk about that. Thank you so much for taking time out of your day to come here and share with us. Our viewers appreciate it.
Thanks
I
for having
appreciate it.
me.
I've learned so much, as always. Such a pleasure talking to you. And so start with our doctors, and also if we're I love that you brought the multidisciplinary. If we're talking to someone not even related to cancer, it might be something, a physical therapist or anything.
Right.
It's always a good thing to maybe bring up that cancer discussion. Not like you're bringing it in, but just like being aware.
And we use speech pathologists, physical therapists. I mean, a lot of times you do surgery and they'll get a stiff neck. So yes, there's multidisciplinary involvement, and
just more ways we can be aware and take care of our body.
Absolutely.
Yeah. All right.
Thank you.
Anything else you'd like to leave us with, Dr. Ghali?
Love you.
We love you too.
That's about it.
And tell everybody to take care of themselves and everything like everything. Just, try not to do that smoking, drink lots of water, get lots of exercise, just generally
all
take
those
care
things.
of yourself. Yeah. And just be aware of all that. And You're here. You're here if we need us and if we need you. So
Thank you.
all right, such a pleasure.
Pleasure to be
Anything else? And look, where are you located, or do you have an office here, or do you just we just call
Well,
you if we need
I'm
you?
located full time at the Willis Knighton Health
Okay.
System. I'm not hard to find. There ain't that many Ghalis around.
Ain't that many Ghalis. No, you are one of a kind, Dr. Ghali. Thank you so much.
Thank you.
We've learned so much, and thank you so much for our viewers. Thank you for calling. Definitely, to both of our viewers, we wish you well and hope that you get well soon, and you'll probably see the other one about her teeth. Very good.
Thank
you again for joining us on Healthline 3, and we'll see you next time.